Good evening. I am Dr. Ellen Hayes. I am a reproductive endocrinologist and infertility specialist at Vios Fertility Institute in Milwaukee, Wisconsin. Vios, which is soon to be Kindbody. I'm joined tonight by Dr. Rodrigo Pagani, who is a fellowship-trained male fertility specialist at Vios, and Dr. Kelly Walker, who is also fellowship-trained in male infertility with Kindbody.
Hi, everybody.
Everyone.
Kelly, do you want to introduce yourself? Maybe tell us a little about yourself, and then Rodrigo will do the same for you.
Absolutely. So I'm Dr. Kelly Walker. I'm one of the reproductive urologists or male fertility specialists, basically the sperm to Dr. Hayes's egg here at Kindbody, based in Denver, but I travel to all of the Kindbodies across the country. And we are so excited to be welcoming Dr. Hayes and Dr. Pagani into the Kindbody group. And they do amazing, amazing work. I've had the privilege of crossing paths with them professionally, and they're incredible. So very excited.
Thank you. Dr. Pagani, would you like to introduce yourself too?
Yep. So I'm also a urologist, male fertility specialist. I have been in the field for more than 20 years now. I'm currently an assistant professor at University of Illinois at Chicago, where I'm based. And I have been working with Vios for the past 5 years, where we are establishing this wonderful opportunity to work together with Kindbody.
Super exciting. Thanks, you guys. Next slide. So as I alluded to, Vios has merged with Kindbody, and so you'll see over the next few weeks to months that Vios will actually be called Kindbody. Our offices will get a little facelift, will look a little different, but we will be the same providers, the same locations, same innovative treatments, and same success rates. But what we're doing by joining with Kindbody is expanding access to amazing fertility care throughout the country. So we're becoming a force to be reckoned with in fertility care. And we like to say, together, we're even kinder. Next slide, please. All right, so today, our agenda, our main topic is male infertility. I'm going to spend just a few slides doing a bit of a fertility 101, and then we'll talk about male factor evaluation, kind of explain the semen analysis in a little more depth, explain varicocele, because a lot of men are diagnosed with that and don't totally understand the impact that that may have and what they should do about it. We'll definitely touch on lifestyle changes you can make and other health factors, and then we'll have some time for questions. So as far as what we need for successful conception, obviously we need a good egg, we need a good sperm to fertilize that egg, we need a healthy uterus, and if we're talking about natural conception or intrauterine insemination, we need healthy fallopian tubes. If we're talking about in vitro fertilization, the tubes don't matter quite as much, but this is what we need to create a healthy baby. So infertility is defined differently based on the age of the female partner, and that has to do with changes as women age in their egg quality. So if the female partner is less than 35 years old, we say that attempting pregnancy for 12 months before seeking help would be acceptable. If the female partner is 35 or older, we kind of shorten that time frame to about 6 months, because we know that egg quality may be declining more rapidly in that age group. And in women who are trying for pregnancy who are 40 or older, it's not a bad idea to seek care immediately. And that can either be as a starting point with your OBGYN or coming directly to a specialist like myself. There are also some reasons why it might not make sense to wait 6 to 12 months to see a specialist. So if you're someone with irregular periods or no periods, or if you know that you have a problem with your uterus or fallopian tubes, endometriosis or known male factor, those would be reasons to seek care right away. So as far as the range of what we see in infertility diagnoses, The one that we're focusing on tonight, male factor infertility, impacts about 30% of the couples that we see. And about 30% of the time, it's actually a combination of male and female factors. But you can see that diminished ovarian reserve and unexplained infertility, as well as some of the less frequent causes, tubal factor, endo, uterine factor, comprise, kind of the total of what we see. Next slide. So how do we begin to evaluate the female partner? Let's review that briefly before we dive into the male factor. So the initial way that we evaluate egg health is with a combination of blood work and vaginal ultrasound, because what we want to understand is the quality or the competency of the eggs, and we want to understand the egg supply. So some of the hormones that we check would be FSH, follicle stimulating hormone, and we have to get an estradiol level at the same time. We usually check these tests around day 2, 3, or 4 of the menstrual cycle to give us an idea about how the brain and the ovary are communicating. And we also check an AMH hormone level, or anti-Mullerian hormone. So that's the blood test that gives us an impression of low ovarian reserve, normal ovarian reserve, or a high egg count. So that can be very helpful as well. The vaginal ultrasound also helps us assess egg quantity by counting the resting follicles in the eggs. We call that the woman's antral follicle count. So we expect to see a certain number of little follicles in the ovaries with eggs inside. And that also gives us an idea, will she be a low responder, a normal responder, or a high responder if we do fertility treatment? So the graph, I know the graph is a little small at the bottom of the screen, but the importance of this is an article that showed us the percentage of normal versus abnormal embryos that women will produce as their age increases. So you can see along the bottom, the age of the female partner goes from less than 32 up to over 45. And the dark blue is euploid or normal embryos. And the light blue would be abnormal embryos. So embryos that have the wrong number of chromosomes and are not viable. And you can see that sort of that 50-50 of abnormal and normal embryos is for most women around 38. And then as the female partner gets older, the percentage of normal versus abnormal starts to shift more dramatically. And that's why seeking care early can be so important. Next slide. So some of the other things that we evaluate would be reasons for ovulation dysfunction. So those of you who might not ovulate, have irregular cycles, or maybe no menstrual period, we look for things like PCOS. We look for hypothalamic dysfunction, and that can be elevated prolactin or various other things. It can be related to thyroid disease, which is very common and becoming more and more common as autoimmune diseases increase. And less likely would be ovarian insufficiency or an early menopause. And then we also want to look at the reproductive anatomy in the female partner. So we want to make sure it's a healthy uterus and a healthy uterine cavity. So the inner cavity of the uterus where the pregnancy would like to implant and grow, and open fallopian tubes. So we do that testing a few different ways. Most of the time we do what's called a saline sonohysterogram, which is an ultrasound with some saline fluid in the uterus. And we can do that in the office quickly, just takes a few minutes. In some situations, we'll still do the dye test, the HSG or hysterosalpingogram, which you can see depicted in that lower picture, where dye goes in the uterus, it flows through the tubes, and we shoot an X-ray picture of that. And we may decide to do hysteroscopy, which is an outpatient surgery to look inside the uterus with a tiny camera, looking for polyps, fibroids, sometimes abnormal uterine shape, and not with hysteroscopy, but with the other tests, we can look for abnormal fallopian tubes. All right, and we're on to Dr. Walker.
Absolutely. And I wanted to, Jay, put a question in the chat, which I think is really, really important about what can be done to change this kind of cultural narrative around the onus and the burden of fertility relying solely on the female or mostly on the female, given that statistically we know male and sperm factors are equally contributory. And I think that's exactly where Kindbody and Vios come in as leaders in this field, really looking at a couple or male and female partners simultaneously and doing that workup in parallel so that we are addressing both partners. So thank you, Jay. You speak to my heart and soul. That's what I hope to do with my life. So speaking of male factor, it's really important to know a little bit more about sperm. And this is kind of the stuff we didn't learn in middle school sex ed. If your sex ed was anything like mine, where they said, if you have sex, you will get pregnant. But the sperm itself, so males start producing sperm at puberty. That's when the testicles really come into their own. One thing to know is that it takes about 3 months for a sperm to start its life cycle in testicles until we see it in the ejaculate. And that's kind of nice on one hand, because that means that a lot of the things in your past don't necessarily affect the sperm that we're seeing today, but we'll touch on some things that do. But it also means that any treatment, any factors that we're going to address, it'll take at least 3 months for us to see those effects. And that's why we really believe in evaluating the male early on in the cycle so that we can be addressing those things while the female partner is going through her workup as well. And there's been a lot of information in the lay press and some really interesting research about the effect of age on sperm. Everyone's kind of thinks about Hugh Hefner having kids well into his later years, but we do see that the quality of sperm tends to decline with male age, generally after about 50. So we mentioned this earlier, but about 20% of all infertility is solely sperm or male related. And then about 30 to 40%, there's something going on with both partners and the male or sperm factors contributing. So what testing or evaluation of the male looks like is there's a bunch of different things we can do, and there's very specific patients based on history that we recommend these various tests. So a semen analysis is always the greatest place to start. It gives you an idea of your baseline and if there's any underlying thing that needs to be addressed. I tell all my patients getting a semen analysis is like taking your temperature. It tells you if you have a fever or not, so meaning are there abnormalities going on, but it's really that workup with Dr. Pagani or myself that'll be able to figure out those underlying causes and how to address it. Sometimes we do a urine analysis, looking for if there's sperm in the urine, meaning sperm's going backwards into the bladder instead of forwards out of the penis. We do a lot of endocrine or hormonal testing because there's a very intricate balance of all of these hormones directing the testicles to make sperm. And then some more advanced tests like DNA fragmentation, which we'll touch on, and then some genetic evaluation. So all of these things is why we think it's so important for when a couple is going through infertility or exploring their fertility proactively to really look at the male side and see a reproductive urologist. You can go on to the next one. Interestingly enough, whenever we do a semen analysis, we always are talking about millions and millions and millions of sperm. It's for two reasons. One is that the testicles are not a very efficient factory. They kind of take a shotgun approach to sperm making. And then the second super important factor is that you need so many sperm, or during intercourse, those sperm have to travel up through the cervix to the uterus, up a fallopian tube, hopefully the side that's ovulating that month, at the exact time that an egg is being released. So that means of all the sperm that come out in the ejaculate, only about 1% of those swimmers have the opportunity to cause fertilization and pregnancy. If that does happen and the timing is perfect and the sperm get there, then there's about a 70–80% chance of that fertilization happening and becoming an embryo. So really a lot more to this process than most people realize. Speaking of, and I've alluded to this a little bit, is that if someone has an abnormal semen analysis and we want to evaluate that and see what's going on, we typically do a male evaluation, which is pretty straightforward as far as the guy's perspective. So we do an extensive history, I say from childhood to now. There's about 40 different things in my differential, which is a doctor's brain of saying these are the things that I think could be going on. And a history is a really important part of that. We also do a physical exam where I say check underneath the hood, see if there's anything anatomy-wise going on. And then based on those two initial parts, we'll determine what additional laboratory evaluation is needed as far as blood work, like hormonal or genetic tests, or specialized semen tests. And then sometimes we do an ultrasound in addition to a physical exam if there's something we need to look at a little bit more specifically. So that's the male factor evaluation. Go to the next one. And the history is pretty extensive, as I mentioned. We look at sexual history, meaning sexual function. There's a lot of different things that come into play with erections, ejaculation, libido, or desire to have sex that influence or can be a key to looking at underlying reasons for infertility. We also talk about pregnancy history. There's a lot of things that we gain from that as far as what's called secondary infertility, meaning you were able to conceive and have a child first time around, but having trouble the second or third time around. Depending on any medications you're on, there's a lot of medications or even over-the-counter things and supplements that can influence fertility. Childhood diseases, like I said, we go all the way back to childhood because there's some things that can affect both the development anatomy-wise, as well as those patency of things to be the route of where sperm travels. Same thing with medical or surgical procedures that can influence fertility, and gonadotoxins, which is a fancy way of saying any environmental exposures that can cause damage to the testicles and their ability to produce sperm. We'll go on to the next slide. And we'll jump into a semen analysis, which is really the crux of what we're going to do here. Rodrigo.
All right, now it's my turn. Sorry, I was muted. Yeah. Okay, so thank you, Dr. Walker. That was amazing. So there are two things that we need to understand when we are talking about semen analysis. First, that even though this is the most important test that we have, it's also not a very good one. Semen analysis is a very good test when it shows the extremes, when it shows that the sperm production is very low or if the sperm production is very high. Whenever is in between, it's kind of a limbo. We might have patients that are fertile or infertile with the same results. And that's why Dr. Walker mentioned that one of the tests that we start studying is the physiology of the sperm. So we are not only looking into the semen analysis, but also looking how well that sperm is functioning. And that's what DNA fragmentation does. That's why the CAP score test does, and other physiological tests that we can do. So the question is, what is normal and what is an average? Okay, next slide, please. So the World Health Organization just released their most updated edition on semen analysis. That's the 6th edition, where they say that a man should have at least 16 million sperm per each milliliter. So if you ejaculate 2 milliliters, you need to have at least 32 million sperm, or else 16 million sperm per milliliter. And you should have 40% of your sperm moving, and more than that, 30% of them moving forward. So it doesn't matter, it's not really good if you have 40% motility and only 10% of that motility is moving forward. The way we classify motility is 3 ways. So we have sperm that moves and goes forward. We have sperm that are twitching their tails, but they are not moving. And we have sperm that are completely immobile. So when you sum up A and B, you should have more than 40%. But when you are looking only into the forward, those who are moving forward, it should be more than 30%. The other parameter that we look into the semen analysis is what we call morphology. Morphology is the shape of the sperm, and we should have more than 4% with normal shape. It is very, very common to see patients with completely normal semen analysis regarding count and motility, and every now and then find someone with a very low streak morphology. We used to be very concerned with patients who had low streak morphology in the past. we thought that low streak morphology would qualify the patient for more, I would say, technological treatments for fertility, like intrauterine insemination or in vitro fertilization. But the most recent studies have been showing that even patients with 0 or 1% of streak morphology, as long as their count and motility is normal, they are able to conceive naturally or with intrauterine insemination without any harm. Next slide, please. Now, what is important for you guys to realize is that when the World Health Organization says that you should have at least 16 million sperm per ml, it is showing that 95%, if you look into the 5th centile column, it's showing that actually 95% of those guys who are able to conceive, they have more than 16 million sperm per ml. And therefore, only 5% of those guys who are able to conceive have less than 16 million sperm per ml. But if you would like to know the average, how many sperm you will need to have in the average, it will be 66 million sperm. So it's much, much different than 16 million sperm that comes on your semen analysis report. So please do not think that having 20 million sperm per ml tells that everything is normal because you are above that 16 million threshold. You are still on the 10th centile, and you will still need some workup to be done to try to get you as close as that 66 million sperm as possible, okay? And the same thing goes with the other parameters. Motility, morphology, they all need to improve to get into the average. Next slide, please. This is another study to show what that World Health Organization chart has told us. This is actually a very important study that was published in the New England Journal of Medicine back in 2001. It's one of the most important medical journals. And on that study, they actually looked into more than 700 couples, and they excluded all female factors. So over here, there is only patients with no female factor involved. And they look into their semen analysis during a year while they are trying to conceive. And you can see that when you compare the fertile range with the infertile range of sperm concentration, they were pretty much the same. It is, you would have an increased likelihood to be infertile if you have less than 13 million sperm per ml, and you're gonna have a higher likelihood to be fertile if you have more than 48 million sperm per ml. But anything in between, it's very much likely to be on both ways. So again, if you see your report saying that you have 16 million sperm, 20 million sperm, that doesn't mean that you are fertile, okay? Next slide, please. Now, the most common cause of male infertility is a condition called varicoceles. Varicoceles are dilated veins around the testicle. It's like varices that we have on the legs. The same thing might happen around the testicle. So the blood flow will go to your testicle very easily because the arteries are working well. But as the veins are not working so well, that blood flow cannot get out of the testicle easily. And that will cause two things. One, it will increase temperature of the testicle. And two, it will increase radical oxidants what else? The cell garbage around your testicle. And that is detrimental to sperm production and sperm quality, okay? And that will increase the chances of having a fragmented DNA of your sperm and radical oxidants on your semen, okay? Next slide, please. Now, this is just a chart to show that patients who went to a surgery to correct their varicocele, or else they had a procedure called varicocelectomy, they had 2.8 times higher chance to get pregnant compared to those guys who did not have their surgery done. Next slide, please. And this is most exciting. Even in patients where IVF is warranted because of female factors, when you compare patients who had their varicocele treated before IVF with those who did not have their varicocele treated before IVF, the group that was treated was performed much better than the non-treatment group. Chances for getting pregnant if you correct your varicocele 3 months before your IVF is 1.8 times higher when you correct your varicocele than when you don't. Next slide, please. Dr. Walker?
All right, so I'm going to jump in here. Anyone who has done any doctor Googling around fertility has inevitably seen a lot of these advertisements for testosterone clinics and testosterone prescriptions. Testosterone is something that has become very popular overall, but especially in this young age group in reproductive years. So I want to do a word of caution for anyone who is hearing about testosterone and kind of considering it, is that testosterone supplementation, whether that's a gel, injections, pellets, whatever form it comes in, is detrimental to sperm production. The idea being that when you take exogenous testosterone, meaning testosterone in a chemical form that your body's not making, your pituitary gland located in the brain says, aha, I have all the testosterone I need. Testicles, you can go on vacation. You don't need to do any work. And I see very commonly guys come in with 0 sperm in their semen analysis, only to find out that they're on testosterone, and that's the reason why. The important thing is that with guys who have low testosterone, there's a different way than we treat it during this trying to get pregnant phase that is not exogenous testosterone, but helps your body make its own testosterone so we can keep that sperm production up and make sure that you guys can get pregnant. So just something to keep in mind as you hear it more and more on social media and society in general, that while you're trying to get pregnant or in this time in life, we address low testosterone in a very different way than taking exogenous testosterone. And a fertility specialist like Dr. Pagani or myself are specially trained to address this in this specific patient population. Given all of the things that you guys are going through to try and get pregnant, this is something that we don't want working against you. So on the next slide, I mentioned a little bit about all the different reasons why we do a semen analysis to get a baseline, see if there's any male factor going on. And I always say that an evaluation with me or Dr. Pagani will accomplish 3 things. 1, you'll get answers. The majority of the time we can figure out why a guy has an abnormal semen analysis. 2, most of the time we can fix that underlying cause because it's reversible. And then the 3rd thing is that we don't want to miss something. So in guys who present with infertility or an abnormal semen analysis, we have found over and over again in different research studies that they are in increased risk for cancer among other medical problems. So this very large study, 22,000 is pretty big as far as medical studies go. They saw an increased rate of high-grade prostate cancer in infertile men were up to 2.6 times more likely to be diagnosed. And then also 3 times more likely to be diagnosed with testicular cancer. And those are super scary things, I understand. But the takeaway is that when we do a semen analysis and do a workup, these are things that can be caught early and addressed really well if caught early. And so that's another reason to really, get involved with this process. If you have an abnormal semen analysis, definitely be evaluated so that we can get answers, fix it, and don't miss it.
All right, so now we are going to touch on some potential lifestyle modifications. Now, of course, the first question I get as a fertility specialist when there is an abnormal semen analysis, and like Dr. Pagani alluded to, we see a lot of them where there's an isolated lower normal morphology, is what can I do to try to improve my numbers? And so some of these things will be applicable to both the male and female partners. So we want to minimize anything that we're doing that could be harmful for overall health, because that probably influences fertility too in both partners. So we're going to focus on sperm for the moment, but this really could be for eggs too. We don't want any smoking or tobacco use of any sort. That gives toxins off in the body, that affects egg quality. It leads to women running out of eggs and poorer quality eggs. And it leads to problems with sperm production and increased free radicals, oxygen radicals that Dr. Pagani was speaking about too. So we don't want toxins coming in the form of tobacco. So cigarettes, chewing tobacco is still a big offender. And marijuana is one that we talk about with a lot of patients, because I think as it becomes legalized, and Dr. Walker, you're in Denver, so you see a lot of that, as it becomes legalized in more locations, people are assuming that it's healthy or good for them, and it's actually not good for male or female fertility. So no smoking, no tobacco use of any sort, minimizing alcohol, to trying to limit to 2 or fewer alcoholic drinks per day. And really, if you and your partner are ramping up toward fertility treatment, you may want to minimize that even further for a period of time. I usually talk to partners about minimizing caffeine, and maybe our urologist friends can weigh in on this too. But I think people are either in a camp where they have 2 or fewer caffeinated drinks a day, or maybe 5 or 6 a day. And so the ones that are maybe 3 a day, maybe that's not going to be make or break for sperm quality, but trying to keep it to 2 or fewer is best. If you're much higher than that, I would suggest trying to taper that down. So I'm going to skip over vitamins because I do want to talk to my colleagues here about this a little bit. So maintaining a normal BMI, so a healthy weight for the male partner as well as the female partner, and normal glycemic control. So really any medical condition that's not well controlled can impact male health and male reproduction and sperm production. Wearing loose underwear and avoiding elevated testicular temperatures. So the underwear kind of falls under that category. Other things like working from home and having your laptop on your lap all day long, every day, might not be the best idea as far as, overheating the testicle. And so hopping back to vitamins, now I usually kind of across the board recommend some coenzyme Q10 for both partners because it's a great antioxidant for egg health and sperm health. I recommend some kind of omega-3 supplement like a fish oil for both partners because it has an anti-inflammatory type of effect in the body. And then kind of erring on the side of a multivitamin for male partners. And because so many people are vitamin D insufficient or deficient, I usually suggest starting a vitamin D supplement as well. Maybe Dr. Walker, do you recommend sperm vitamins for your patients?
So it's a very interesting topic with a lot of controversy around it. And I always come back to the AUA, or American Urologic Association, actually has guidelines where a group of experts in this area looked through all of the research studies that have been done on various topics. And one of their guidelines is around supplements or vitamins. So some of those studies show that there are modest improvements in certain semen parameters with guys who are on antioxidants or vitamins. And some of those studies show that that doesn't make a difference. So overall, the conclusion is that there's a potential benefit, which has not been well demonstrated in studies, but there's no real downside. And so when I talk to my patients, I say, just know that taking a supplement may provide some modest improvement, but it may not have any effects. So I say, don't spend $1 million on this as, you know, the thing that's going to be the magic bullet, but it definitely doesn't hurt. And exactly like Dr. Hayes said, we're really focused on that idea of antioxidants, which will neutralize the free radicals or radical oxygen species that Dr. Pagani talked about that hinder sperm production or decrease sperm quality. So exactly like you said, there are lots of different studies that looked at lots of different vitamins. No one has been shown to be any superior to the other, but those ones that Dr. Hayes mentioned are the ones that have been studied.
Thank you. Dr. Pagani, anything else that you
No,
recommend?
I agree completely with Dr. Walker. I would just like to add that in the medical field, there are several types of studies, right? And most of the studies that you guys see out there showing some benefits from one antioxidant or vitamin, they are usually only observational studies. They are not conducted the way we say as a double-blind, placebo-controlled studies. So there are not many answers out there to say that vitamins and supplements can really help. I think that the most studied one is CoQ10. So I do tell my patients to take CoQ10 when they have fertility issues, especially in cases where I need to improve their motility, and sometimes when they have what we call an elevated white blood cells in the semen. So those are, CoQ10 might help patients to decrease those white blood cells, which are inflammatory cells, and also improve their motility rate.
Yeah, so I would add to what's listed here also, just as far as overall health, I mean, that can have a huge impact on reproductive health. And so outside of even having a normal BMI, I think focusing on nutrition, a lot of patients and a lot of us can benefit on improved nutrition, making sure we're getting a lot of fruits and vegetables, complex carbohydrates, maybe less meat and dairy. And also regular exercise, in men and women, that can be beneficial. It has anti-inflammatory effects on the body in general also, but can be good for fertility too, not only maintaining weight, but also because exercise is good for you. So I recommend healthy diet, regular exercise for both partners as well. Is there anything else you guys would add to the lifestyle modifications?
I would add that, again, about the BMI, I think that obese patients tend to have lower testosterone levels because of one, particular condition that happens at the adipose tissue that we call aromatization. In other words, parts of a good hormone for us called testosterone is converted into another hormone that is estradiol, which is not so good for sperm production. So obese patients may tend to have a lower testosterone range, a higher estradiol level, and that may affect sperm production. So keep your exercising, and a good body mass index would be ideal.
Yeah, absolutely. So we will get to questions. So basically, there's no right or wrong order to see physicians in. If you are a man who knows he has an issue with semen analysis or problems with reproductive health, it's perfectly fine to seek out a male fertility specialist like Dr. Walker, like Dr. Pagani as a first step. Then, if necessary, they will refer you on to a fertility specialist to help with fertility treatment, like myself. Otherwise, oftentimes the way that flows is couples will come to see me, we'll do basic evaluation, and then we will refer to a male fertility specialist when we're finding problems that warrant further evaluation, and allow them to help us and collaborate. So how about we go to the chat and start answering some questions. Does that sound good?
Yeah,
All
let's
right.
do it.
So I'm just going to start back at the beginning of all of these questions. So one of them is, what role does DNA fragmentation have? Dr. Pagani, do you want to address this one?
Okay, so DNA fragmentation may impact fertilization, embryo formation, and also it's highly linked to recurrent pregnancy loss. DNA fragmentation is still, I would say, a test that is more on the research side than on the clinical side. We don't go ahead doing DNA fragmentation in every patient, but I do think that there are some patients who benefit of having a DNA fragmentation tested. Those patients are, number one, patients with recurrent pregnancy loss, patients with recurrent IVF failures. They tried 2, 3 IVF and they are, they are not having success. I would add a third one, which is patients with unexplained infertility. We do every test, everything is normal, and we don't know why they are not getting pregnant. And the fourth one would be on patients with varicoceles. And when, if a patient comes to me with a varicocele and a normal semen analysis, it's very easy to tell them to perform surgery, right? Because you had a low sperm count, and then you do a surgery to improve your sperm parameters. But there are some guys out there with a fairly normal semen analysis, 25 million sperm, normal motility, normal morphology, and the female partner is completely normal as well. Those patients may benefit from DNA fragmentation test. And then if the DNA fragmentation is elevated, then and only then you will correct their varicoceles.
Thank you. That's great information. I think we already kind of covered how important is sperm quality with IVF. And is morphology of 2% normal with good volume and motility considered male factor in fertility? Dr. Walker, I know we kind of touched on the fact that isolated morphology issues may not mean that couples can't conceive. Can you expand on that a little bit?
Yeah, absolutely. So as Dr. Pagani, I think it's really important to understand when we talk about these normal or reference ranges, it is the 5th percentile of normal people according to WHO. And so when someone has a mild abnormality, meaning just morphology, and it's at 2%, I ask them, where are you guys in your fertility journey? If you're towards the beginning and you're just saying, hey, we got a semen analysis to make sure there's no huge red flags and we should continue on trying on our own, then I think that's a very reasonable approach. If, on the other hand, this couple says, we've been trying for 6 months or a year, we haven't had any luck, we did this whole workup, we haven't found anything else that's wrong, should we do something about this 2%? I say you've had the test of time. We've seen with this abnormality that you guys have not been able to get pregnant on your own. So it may be time to do a deeper dive and see if this is a male factor contributing to that difficulty getting pregnant.
Perfect. Thank you.
Yeah.
Okay. Next question. How is sperm quality affected by antidepressants? Who would like to handle this one? This is sort of a broad question because there are many different medications that could fall into this category. Dr. Pagani, do you address obviously medications that men are on and recommend that they change or stop them sometimes?
Yeah, definitely. But antidepressant doesn't seem to contribute to male infertility, although there are some side effects that are important for reproduction per se. So antidepressant may cause low libido, which is low sex drive, right? And also some patients may have delayed ejaculation due to the use of antidepressants. Some guys sometimes will have sex for a longer period and cannot achieve ejaculation due to the use of antidepressants. But it doesn't seem to have any harm on the sperm production per se.
Okay, perfect. That's very helpful because obviously being able to maintain an erection, ejaculate normally is critical as well. So if it's having an impact on those areas, then maybe it is possible to talk to their prescriber about changing medications or trying to decrease their dose. One of the questions was, if a male has a blockage, can he still impregnate his partner? This could mean, I think, various things, but Dr. Walker, can you address some of those?
Absolutely. And Dr. Hayes alluded to it. It all depends. So I tell everybody it takes one moving sperm to get to an egg and cause pregnancy, but the probability of pregnancy happening is very low with one moving sperm. So where that comes into play with blockages is that it really depends on two different characteristics. The first is where that blockage is located. So 2 testicles, 2 epididymis, 2 vas deferens, 1 ejaculatory duct. So if you have a blockage on any of those areas that has a counterpart, then you're still getting sperm from the other testicle. If you have that blockage on both sides, for example, a vasectomy, typically as both sides of vas have been interrupted or blocked, or there's a blockage farther down where it's after those 2 tubes have come together, then there is a significantly decreased chance of getting pregnant because presumably with a complete blockage, there's no sperm getting through. So the first thing is about where the blockage is located. And then the second is if it's a complete or incomplete blockage. So it's really dependent on those things. And we can usually, between a semen analysis and a thorough history, be able to determine exactly what's going on.
All right, excellent. Here's another question. So thoughts on Clomid for men? And specifically, they were saying their husband had a semen analysis with low numbers, was put on Clomid, and numbers went up significantly. Unfortunately, in their case, the numbers then declined again. But I'm interested to hear your thoughts. I see a lot of men that are put on Clomid without any hormonal evaluation. And obviously Clomid is not going to work for everybody. So checking male hormones can be helpful in making that decision, correct?
Absolutely. So as we alluded to earlier, I tell all my patients that the hormone system that regulates sperm and testosterone production is like cruise control on your car. You have FSH and LH, which is the signal to the testicles to make sperm and testosterone. And then you have the testicles, which are the engine that are actually doing that work and making that sperm and testosterone. When we do a hormone panel, we're able to determine if there's a low sperm count. Is it due to low FSH and LH and low testosterone? In that case, Clomid is a good option. I say it's like putting the foot on the gas and increasing that signal to the testicle with the hopes that we increase sperm production. It's super, super important though, when we have guys that we put on Clomid. One, like I said before, we want to make sure we only put the appropriate guys that it's going to treat that underlying problem. And then secondly, it's super important to follow that hormones and see how they change. Because the same way that we can put the foot on the gas and increase sperm production, there's lots of downstream effects. We want to make sure we don't push the system too far the other way, which can actually have negative effects and end up decreasing sperm production. So as far as Clomid or any kind of hormonal manipulation or medications that we use for male fertility, the 2 takeaways are that 1, we want to make sure we do a thorough evaluation with a hormone panel to determine the appropriate medication and the appropriate dose. And secondly, we want to follow those hormone levels and see what each individual's response is to that medication so that we can adjust or change if needed.
All right, thank you. All right, here is another question. We have so many questions. Hold on. Let me scroll to the bottom and just make sure we're Nexium. Okay, is it true that men over 40 have sperm that has a higher chance of causing autism? We talk about women's ages, but can we talk more about men's ages? Dr. Pagani, do you want to talk about that?
Yes. So, yes, it seems to have a relationship between paternal age, especially after 50 years old, and some diseases. And one of them is autism. The other one is schizophrenia. And a third one that is linked to high paternal age would be dwarfism. So there are some diseases out there that are linked to paternal age. And also there's increased likelihood for Down syndrome as well, as we also see in the females when they get older. So it is a concern, even though we know several histories of patients who are able to conceive after 50 years old. It is a concern that with time, their sperm may carry some conditions that can cause some diseases to their offspring. Now, is that too much higher than the normal population? Fortunately, it's not. So it will increase, but it will increase just a little bit.
All right, thank you. There was another one here. Does ulcerative colitis and those medications involved for treatment have any effect on sperm? So I know that's really specific, but maybe just addressing just overall health. And I assume that it's best to optimize autoimmune conditions and those types of disease in the male partner as much as it is in the female partner. Dr. Walker, can you talk about that?
Yeah, absolutely. And this is one of the things where I think it's important that as reproductive specialists, we know and are familiar with certain medications and certain conditions and how they influence reproduction. But it's also something when we talk about certain medications and looking at the risk benefit. So when we're talking about something like ulcerative colitis or other immune conditions where patients are typically on immune modulating medications, it's important to first and foremost control that condition. So even if we were to take you off that medication and you had an ulcerative colitis flare, that would probably be more detrimental than a small potential effect of medication on fertility. And so that's why it really is a more involved conversation of weighing the risks and benefits of why you're on a certain medication, and is there an acceptable or good alternative that can control that underlying medical condition adequately while minimizing the effect on fertility. So those are the weighing conversations that I have with my patients all the time.
Yeah, absolutely. I think we can't underestimate health conditions that impact overall health, as well as longevity and the impact on reproductive health. I think we are coming up on an hour. So I think we're going to wrap things up. Any last words, Dr. Pagani, about anything that maybe we didn't cover, or maybe encouraging people to seek help early from a male fertility specialist?
Yeah, so the first thing is that it's important to know that about 30 to 40% of the couples out there is not getting pregnant because of semen and sperm issues. So, we tend to take the burden to the females more often than we should. And it's very important that their partners are examined and tested by a reproductive urologist at the same time as their partners are being tested. Luckily, we can do this at Kindbody with Dr. Walker or at VIOS with me. And soon we'll be joining our forces.
Absolutely. Dr. Walker, anything else you wanted to add?
Yeah, I just have to echo that. I think access and awareness around the male contributor to infertility is something that we are just starting to really grasp as a society and a culture. And with this partnership of Kindbody and Bios, we really are going to be able to give our patients the access to specialists like Dr. Pagani and myself and Dr. Cowan, who's also my partner here at Kindbody, who does male fertility, and really provide couples with this idea of integrated care where both couples are being addressed simultaneously and worked up so that we are getting the whole picture. Which is why I'm so excited to work with Dr. Hayes and Dr. Pagani and make this a reality for all the couples we take care of.
Absolutely. Absolutely. I think I'll just add that we don't want shame or embarrassment to hold people back from seeking out care. Seek care early. We can help. There's much more sophisticated evaluation for the male partner now than there was even a few years ago. And so I think we just need to keep this conversation going, make more people aware of options and that there are treatments available and that they just need to come and see us to learn about their options and get the family that they're dreaming of. So if anyone watching today would like to schedule an appointment with Dr. Walker at Kindbody, you can visit kindbody.com. For the short time being, if you want to see Dr. Pagani or myself or any of the physicians at Vios, it's viosfertility.com. Soon we will all be one Kindbody and one website, but please reach out if you have additional questions and we can help you out with your fertility journey. And thank you so much for joining us tonight, everyone.
Yes, thank you, everyone.
Thank you, everyone.